Thanks for joining. This is Carol from the Society of Thoracic Surgeons for the Adult Cardiac Surgery Database Quality Improvement Series on decreasing vent times. Today is October 18th, and we're going to be reviewing the data from Harvest 3 on decreasing vent times to see how we've been doing. On the line with me is Leanne and Melinda, and we have a nice attendance for our participants. So thanks for joining. Harvest 3 reports were released over the weekend. First, I'm going to do some quick polling just to get this out of the way. It's always nice to have some engagement, and if we're ready to do that, let me launch these. Some of the questions are about AQO 2023, AQO 2024, and then we'll have just a couple quality improvement questions. The first set, hold on one second. Sorry, everybody. I need to make it so Melinda and Leanne can see the questions as they come in. Let me do that. There we go. Okay. So the first set of questions is for AQO 2023-2024. They all need to be answered before your questions can be before the polling can be submitted. There's 4 questions. The first question is, did you attend AQO? Yes, no, not yet, but planning to purchase the content, enjoy the Hot Topics, and join the Hot Topics webinar, which will be in December. AQO 2024 will be in person. Do you hope to attend live? Yes, no, not sure. We don't have a day. We don't have the location finalized. We're near finalizing the location, so I can't yet share it, but we're hoping to be somewhere Midwest, and it will have limited attendance. So early signing up will be encouraged, and I'll give you more information on that as soon as all the contracting stuff is done and I'm able to share, just so you can start making plans if you do want to attend. And then the third question is, if not in person, do you plan on purchasing the recorded content after AQO? And just like we did last year, we'll have everything recorded and then available for purchase after AQO. We will also still have a Hot Topics webinar. So if you aren't able to attend in person, you still have some opportunity to ask for the live Q&A and for live discussion after AQO. And then if you attend or hope to attend, who's paying for it? Are you paying for it yourself? Is your employer able to support it? Are you going to split costs, or you will not be joining? If you don't know, just put what you think would happen or what has happened in the past. And I'm going to let this go. We got a good participant. Thanks everybody for answering. We're going to give this a few more seconds. A couple people still answering the questions. And I'm going to cut it off in about 5 seconds. All right. Thanks, everybody. So here are the results. Most folks did attend AQO in person, 125 of the 222 that answered the question attended in person. So thanks for joining. We have a couple people who will be joining us for purchasing the content and then joining us for the Hot Topics webinar. We'll have that available to purchase coming up soon. We're just moving the content over platforms. And once that's complete, then you can purchase it. You do have to claim continuing education credit. Make sure you claim that by December 29th. I think that's Friday. Whatever the last Friday is in December, make sure you claim your continuing education credits. And then AQO 2024 will be in person. It looks like we have 82 folks out of the 222 said, yep, they're attending. 55 or 25%, 55 people, 25% said they're not able to attend, and 38% said they're not sure. AQO in person is a great way to meet everybody. Some old friends make some new friends. The content is always wonderful, and it's great to see everybody in person. And then also the ability to go out and socialize afterwards is always fun too, with your friends that you from other coasts that you don't get to see too often. And then do you plan on purchasing the recorded content if you're not able to attend live AQO in 2024? Yes, most folks will purchase it, or they're not sure about purchasing it. And of course, there's about 20% of those that answered that are going to definitely plan on attending in person next year. And then if you attend in person, who's paying for it? 46% said their employer, 20% said it would be out of pocket, and 11% said that they would be splitting costs with their employer. So thanks for answering those questions. And I'm going to take this back to our team internally just to share as we finalize the plans for AQO 2024. And then the next set of questions is related to quality improvement. Here you go. So the first question is, have you found these webinars in instituting or continuing? Have you found these webinars helpful in instituting or continuing a QI project related to vent times at your facility? The second question is, do you have an ongoing QI project or plan to soon start one using the adult cardiac database data? The third one is, would you be interested in sharing your QI projects on vent times on an upcoming webinar? I'm looking for folks who are interested in presenting their quality improvement projects. Unlike all the other presentations we've had so far that have been wonderful, sharing what you've done at your facility or what you're working on. Have you, and you don't, your contact information, I would have it and I could reach out to you. The fourth question is, have you found benefit in joining these QI webinars? If so, can I contact you to learn more? And I hope you like my choices for that one. And then fifth is, vote for the next QI project: blood usage, length of stay, ICU time. We're going to continue with the vent project probably for another, at least I want to run this one for about a year. So we started it last April and we'll run it through at least March of 2024. And then after that, we may switch over. I want to see how good we're doing after Harvest 1 data closes, and then Harvest 2 data would be a year. So I'm going to keep watching this. So everybody's answering their questions. Please take your time to get your answers in. And I only have 4 takers on people. 5. Please, if you're if you want to share your QI projects on vent times, I would really appreciate you doing so to these webinars. It's a safe place to share. Everybody who has presented has had a great support from the STS and from all the attendees, so there's no need to be nervous about it. And we just want to hear what you're doing and what tips you can share with others so they could do the same. Thanks, people, for not being mean on number 4. And thank you for those who are offering to share their what they found beneficial in these QI webinars. Our marketing department always asks me for feedback, and it's always better to come from those that I'm giving or that we're educating than coming from me and saying, oh yeah, everybody loves it. They would rather hear from you about it. So, and of course, be honest and open, and you don't have to like everything, but share that information too if there's things like that we can improve upon. We always want to know. And no, I don't like it, and I'm not telling you why. Oh, okay, that's okay. All right, I think we're good here. Annie, I'm gonna let this run for another about 10 seconds to see if we get any more responses.
Carol, you've got some questions in the chat. I don't know if you want to look there, or if you just want me to turn the chat off so everything can go into Q&A, just let me know.
Yeah, I'm scrolling through it, but if people could put it into the Q&A, if we could shut it off, Leanne, that'd be really helpful. Thank you.
Okay, got it. I'll take care of it.
For Nicole, regarding question 3 on vent time presentation, I would be on the presenter, so I wouldn't be the presenter, so I can't obligate. No problem, Nicole. And no, regarding number 5, we monitor all and would be interested in all. Thank you. And right. I think I am going to end this poll and let's see everybody share everybody's responses. The majority of you have found these webinars helpful in instituting or continuing a QI project. Some of you have not found them helpful, and 30% responded NA. If you haven't found them helpful, let me know what, feel free to email me, that's fine, what you think would be more helpful in these. Is it just something that your institution isn't focused on, or is there something that STS can do to improve sharing information from other sites to do these projects? For the second question, do you have an ongoing quality improvement project or plan to start one soon using the STS adult cardiac database? About half of you have one in progress or are planning it, 10% are already done, 31% do not, and 12% are NA. Would you be interested in sharing your QI projects and vent times on an upcoming webinar? 6%, 10 folks responded yes. So I will be reaching out to you to get more information on those projects and see if we can schedule you to join one of these webinars. How you found benefit? Sorry for that wording on those. Have you found benefit in joining these quality improvement webinars? If so, can I contact you to learn more? Yes and yes, and I will tell you why. So I will likely be contacting you, or somebody at STS will be contacting you and looping me in, just so we can hear more about how these have been helpful to you. No and yes, I don't like it, and I'm not, and going to tell you about it. Please let me know why you don't, or if there's anything we can do to improve upon them. And no and no. And the same thing, don't be shy if you don't like it, or there's some way that we can improve. Critical feedback is always helpful. And then for voting for the next QI project, blood usage has, that's the one I picked first to begin with, and I think that's where we're going to focus. All of them are important, and we will get to all of them. I just wanted to know which one we wanted to focus on next, so I could do a little bit more information. Gain a little bit more information before we start that project, so I can focus some of my work on that. All right, thanks everybody. And now, hold on, let me see. Okay, I'm going to go through the questions towards the end, and we'll get to those. To continue on for the webinar today, we're going to go through the Harvest 3 results related to vent times. First is important dates. We have the quality improvement webinar today. November 1st is the monthly webinar. I think we're going to focus on Harvest Close. Is that right, Melinda? And if you all think that that you're good with Harvest Close and we don't need to do another webinar about it, that's fine. We can switch that up and do education. Let me actually do a poll, see if I have a poll available.
Either way.
Yeah, let me see.
Depending on what they want.
Let's see here. Hold on. Oops. If you could go ahead and just give a thumbs up. Oh, what are our emojis that we have?
We have thumbs up. We have a crying. We have a heart. We have clapping hands.
Okay. Thumbs up if you want us to do the, and I'm going to ignore everything that just came in. Wait for me to give you complete instructions. Thumbs up if you'd like us to do the Harvest Close preparation webinar, or give us a laughing face emoji if you want us to focus on other abstraction education.
Oh, wow.
Looks like the laughing face is the.
Yeah, it looks like the laughing faces.
It's like they want education.
Yep.
Unless somebody's hitting their mouse button real fast. Okay.
Okay, I'll start working on my slides.
All right, we hear you. We'll do some education, and then we'll also provide the link to the last data webinar, or the last webinar we had on data cleanup, so you can refer to that as well prior to the harvest close on November 10th. And then November 14th is the opt-out ends for Harvest 4. Don't forget November 10th, the Harvest 4 deadline. It contains OR dates through September 30th of 2023. Be sure to get your data in as early as possible. This is observed Veterans Day. We will not be moving it, as Veterans Day is on November 11th. Knowing that this is the observed day, I certainly want to respect veterans and those who, veterans' families who may be honoring your loved ones this day. So please be sure to get your harvest in, your data in early, so you can enjoy this time with your family and loved ones during that time. November 14th is the harvest opt-out ends. November 15th is the quality improvement series at 2 p.m. Central Time. And December 6th, I can't believe December's already on our important dates calendar, is the monthly webinar at 2 p.m. Central. And we will be, it depends what that one is going to be. More information to come on one of the upcoming webinars, but what we'll talk about on December 6th. If you are interested in presenting on November 15th for a quality improvement project at your facility, to share your project with us, your best practices, please reach out to me after this webinar and let me know. I need somebody who's able to present on this day, so we can have a nice audience for you and help you get ready to do that. So next slide. All right. So back in April, we started this national quality improvement project with the idea that we were going to reduce prolonged ventilation, the numbers of prolonged ventilation patients. In that, we look at average vent hours, shortening average vent hours. We look at improving extubated and OR patients, improving extubation within 12 hours, decreasing ventilation longer than 24 hours. So there's a whole quite a bit of variables that we look at related to vent hours. And when we started this project, we said we were going to focus on isolated CABG, which is PROC ID 1. So isolated coronary artery bypass graft. This is the slide I showed at the beginning back in April. And can't believe that's now been 6 months, but it has. So we looked at this slide from 6 months ago. I added in a couple vertical lines. I added in a couple vertical lines. The horizontal lines had been there. So this is our data we had from Harvest 1 of 2023, which was through December 31st, 2022 OR dates. I marked the 24-hour time here. That's our definition of prolonged ventilation. I marked the 12 hours and I marked the 6 hours. 6 hours is what we define as as early extubation. So that's kind of like a goal for patients who are clinically appropriate, that we would want to see those patients 6 hours. And if you all recall, Dr. Whitman presented back in April that patients, there's a lot of data out there, a lot of research articles out there that identify patients who this 12-hour mark is an important milestone when we're looking at increase for poor outcomes following coronary artery bypass surgery. So this is also one of the goals we wanted to highlight. 24 hours, of course, is that mark where you'll get dinged for prolonged ventilation. Lots of bad things happen if patients can be intubated greater than 24 hours. And we've reviewed all of those, including the clinical and anatomical aspects of why that's important, and also from a business side about getting buy-in from those who support these types of projects at your hospital, and why this mark is both of these 12 and 24 hours is important for many stakeholders at your hospital. This mark here, this cross is where we're looking at those patients these are all the patients these are the sites. So these are the average or mean vent times at the sites that we had in analysis. We did not have 1,021 sites in analysis per se. We had 982 sites in analysis, but sometimes sites drop out of the database or they don't submit new data. So they're not receiving analyzed results back, but we do include their historic data in analysis. So that's why we had data from 1,021 participants. And that's why that number is higher than the number that received that were included in analysis, if that makes sense. This number here, right around the 886 mark, is where you could see sites average vent times break that threshold of greater than 24 hours. These sites here in this, what would be a red box, if you want the red and red outlines here. These sites here have a mean vent time of prolonged definition greater than 24 hours of the average at their hospitals that patients will be intubated longer than 24 hours. And then we have this group here, patients are within this box here. These patients or these participants, their mean vent times are less than the 24-hour mark up to, and we're looking here at the 12-hour mark. These sites here, their mean vent times are less than 12 hours, and these sites here, their mean vent times are less than 6 hours. So these are the very, very, very great performers. These are the performers that need a little help, and these folks are doing good, but we need to still continue to improve. So that was from where we were at. And now on the next slide, you'll see where we are using the Harvest 3 data. And this is, again, OR cases. We're focused on isolated cabbages, OR cases through June 30th. We've only been running this project for 3 months at this time, right? April, May, June. But what you can see here, and I'll show you, I had our research team run an analysis on this. When we look at all of the data compared across time, I'll get to the slide in a second, you'll see that there's a statistically significant decrease in mean vent times, which means that not sure if it's related to this project or if it's a national trend in all, but whatever's happening, the average vent times are decreasing. So that means that it's good, right? We're getting patients off vents earlier, saving lots of resources, saving the patients from complications associated with longer vent times. And we'll get to that in a second. This is where we're at for H3. And what I'm going to show you is the idea is this is the 24-hour mark, right? You want to see this get further to the right. You want to see this scoot down because you want to see less sites that have an average prolonged vent time, an average vent time that is greater than 24 hours. We had 1,009 participant data and analysis. We had 1,011 sites in analysis. We had 927 sites that submitted data for this harvest. Again, remember that sites that may have opted out or have been removed from the database for whatever reason, their historical data is still included in analysis. And that includes sites who, if their historical data was appropriate and they had met all those reporting thresholds, including volume and mortality fields thresholds previously, their site has, but for whatever reason they didn't meet them this harvest, their historic data is included, their current data is not included. So we have 927 sites in Harvest 3. Our average event time for Harvest 3 decreased from 15.3 in Harvest 1 down to 14.42. Our ends this is our end total number of cases analyzed was 449,000 isolated cabbages. And again, this is just a little bit higher number. This is the analyzed data set. So you want to see this scoot over to the right. And when we go back to that previous slide, it's hard to see it here, but that's why I had our analytics team run some additional data because there are more sites here where, we're looking at this and the graphs aren't the same size and all of that. So we'll get to the analyzed data set. This is our previous Harvest 1. This is Harvest 3. And then you want to see, these are the sites who their average event mean times are somewhere between. Hey, that guy moved on me. He should have been right about here. Right about there. Okay. This is the group here, actually should be right about there. This is the group here that their mean vent times are less than 24 hours, but still greater than 12 hours. This is the group whose mean vent times is, between 12 and 6 hours. And then here's the group. So you want to see this green bar as we continue to track these quarterly. The idea is that we want to see this green bar scoot more to the right. This bar, it's just a good gauge. We would love to see it scoot more to the right. And this bar, we want to see scoot more to the right. This one isn't as important. This one is the one, all of them are important. This one is the prolonged vent. So that's where we're at for harvest 3. And then I broke it down. Here is our p-values that our research center ran for me. What you're going to see here, I got a little confused when I read it the first time, so let me walk you through it. We start here with January 2022 data, and we go through June 2023. Our our quality initiative started here on April 2023. We have error bars for 95% confidence intervals, and patients who were extubated in the OR were excluded from this calculations. What we're looking at is mean mechanical ventilation hours versus time. So time is our months, and then we're looking at average vent times. We broke this down by 6-month periods. So you'll have this blue set is from January through June of 2022. The orange set's July through December of 2022. The gray set is January through June of 2023. The p-values are looking to see, well, you'll see this p-value up here. It's comparing the orange to the blue. The p-value is provided in blue. We're looking for p-values that identify statistical significance. And when we compare, we're looking at if there's any statistical significance between what happened in this 6 months compared to this 6 months. A slight could be something here with a p-value of 0.02. When we get over comparing the next 6 months, which includes our 3 months, and you can see this large drop here, we get comparing this next 6 months to in the first 6 months of 2022 and the last 6 months of 2022, there is statistical significance and a decrease in mean vent times. So this is what we're interested in. We're going to keep tracking this. I don't think it's just a fluke. This is the lowest vent time, mean vent time that we had, and the end that we had for this was 4,449,000 cases, which is a large number of cases for any type of analysis. So we will continue watching this. I want to say good job, but I think we just need to be cautious and continue working hard towards our goal of decreasing mean vent time. So good job, everybody, and we're going to keep doing this. And we'll keep watching this, keep making sure that we're doing good, and then tweak it as we need to go along. I think that's really great. And more information will be provided with the Harvest 4 that closes in November. So great job. You all should be very proud of yourselves, especially if you have pushed for this initiative at your hospital or have been a support to the people that have been leading these by sharing information. So previously we looked at volume sites, sites by volume. We looked at high, moderate, and low volume sites. If y'all remember back in April, high volume is defined as 12,000 or more cases for the 36-month analytic window. Moderate volume is defined as 600 to 1199. Low volume is 0 to 599. It was interesting. I just put these together off of some raw data. This is what our analytics team provided me. So I believe, what they did, it's good work. They're an excellent analytics center. So this is just me putting data together. This is the previous slide we looked at in April, high volume sites, average vent times. There's 41 centers that were in analysis that were considered high volume. 2 of those sites have average vent times that are greater than 24 hours. The majority fall within this 12 to 24 hour range. And then we have these sites here that fall within the 6 to 24 hour range. We have no high volume centers that have an average vent time of less than 6 hours. It's not saying that that's bad or good. It's just, it's just the way it is. Likely high volume centers may have higher risk patients, so we pay attention to that as well. With risk adjustment, this is not risk adjusted. Their mean times are not risk adjusted, but we're going to get to that in a second. So there's that. The STS average was 15.3 at that time for H1. In analysis, the STS average was 15.76 for all high volume sites, so it was a little bit higher. Now, this is where we were at in April. Now, where are we at now? We had 77,000 cases from our high volume sites. We still have 2 sites who have a mean average vent time greater than 24 hours. We still have no sites with a mean average vent time less than 6 hours, which there's many reasons why that could be. Not that it's bad or good, just that this is what the raw data is. And then we have these sites here. So we watch, right? We want to see this bar scoot to the right. This is a lower number of sites. We only have 46 participants. We'll see these bigger shifts with the moderate and low volume facilities. Okay, so that's current. This is the moderate volume site, and you can see this is what we provided last time. And it's hard, these numbers kind of run together, but there's 186 participants here. I didn't get the N for some reason. I didn't have the N last time we presented this, but I'll continue doing so going forward. Our goal is to see that this red bar scoots over to the right and that this bar scoots over to the right. So let's continue. And it's just about the same. We're at 172. This is current data for moderate volume sites, average vent time through harvest 3. We had 155,000 cases from 193 participants that were analyzed. That's a lot of data. We have it's like 2 or 3 sites within this group that have an mean average vent time of less than 6 hours. One site even has mean average vent time less than 4 hours. Again, we're excluding extubated and OR patients. So I don't know who this site is here or who these sites are here, but it'd be great if we could hear from you. And then we have these sites over here that have a mean average vent time of greater than 24 hours. Hopefully they're on the calls and we're able to work together to help bring those vent times down. And I did remove low volume cases when I built these graphs. I removed well, this didn't matter. All of these, your annual volume or your 36-month volume was 600 to 1199. So there was significant cases for both of these sites here. So it's not like these sites just had 1 or 2 cases that are causing outliers. It was the mean time for all of their cases. This is the low volume sites. You can see we have many more low volume programs. For this, we had a total of, this was from April of this year, so Harvest 1 data. These sites here with an average vent time. And I tried, since it's low volume, 0 to 599 cases, I made a cut at 10 cases. If any site had less than 10 cases, I just removed them because I didn't think that would be helpful for this graph. So all of these sites here are performing with mean vent times less than 6 hours. These sites here are performing mean vent times greater than 24 hours. This is where we're at now. We had 772 participants fall into the low volume site definition with a 225,000 cases. We have it's probably right around 30 sites who have a mean average vent time of less than 6 hours. And we have also a significant number of sites who have a mean average vent time greater than 24 hours. So what we want to see, this is pretty wide out where we look at the 12-hour sites who have a 12-hour mark. Sites who have a 12-hour average of less than 12 hours. About 220 sites of the low volume have mean vent times of less than 12 hours. Their end's a little bit smaller, but still significant. So we'll keep watching this. We want to see, again, like I said, we want to see the sites, the count of participants who have mean average vent times greater than 24 hours decrease. And we want to see those who have mean average vent times of 12 hours or less than 6 hours increase. So we'll continue watching that. And then I also looked at the activated and OR cases. And this goes back to July of 2020. It has been continuously trending upward. So we looked at that. This is by month, so 637 cases. It's the highest we've ever had in the last 3 years of cases extubated intraoperatively. So there's definitely trending going on here. We'll keep an eye on this. We did have some great information from our when Hannah Whitley presented, her anesthesiologist presented information about how they manage those patients intraoperatively to try to get them off of the ventilator prior to or near leaving the OR, and as long as they're clinically appropriate, how they do that and how they make that assessment. And we also heard from a few other presenters on that same type of idea. So it is something that's definitely trending that we need to watch and encourage our teams to be aware of, presenting data at our monthly meetings or anything like that. We'll just get the word out that it's something that we're watching, I think, and you're watching, and why it's important. The last thing I looked at was on our longitudinal dashboard. I pulled this right out of the longitudinal dashboard, and I'll show you how to do that. You can look at it for your site. What I pulled out here, this is the STS risk-adjusted prolonged ventilation. And I exported it. I looked at whatever was in the database from, and it looks like we go back to January 1st of 2017 through, this is this is Q2 of 2023. So when we stopped or when we started our project, and there was already a slight trend of decreasing prolonged ventilation times nationally. This is again risk-adjusted data. So even taking in the risk of the patient, it still looks like that trend is decreasing. I pulled out separately Q1 and Q2 of 2023. This is pre-initiation of our quality improvement project. This is when we started it. There's a definite decrease and a significant trend going down. We're going to continue to watch that as we continue with this project. So I think that you all should be very proud of yourselves. I'm just sharing information and putting these talks together. You all are doing the hard work at your sites and getting buy-in from your surgeons and teams, and I just wanted to share this with you from STS perspective and how cool I think this is that we're doing this together on a national level. It can have significant impact on not just patient care, but we're talking about the whole healthcare system when we look at spending and things like that. And we have a healthcare crisis in our, you could say, right, we always talk about what's wrong with the US healthcare system, but we're doing something together to make it better. So we should all be very proud, and I'm proud of you guys. So thank you. And that's what I had for today. I'm going to go over to questions. Melinda, do you have anything to add?
No, I think everybody's doing a wonderful job though, looking at those numbers.
Yeah, it's amazing. Like I said, at the first webinar in April, I said what a small group of people can do, right? I think that statement had come. It was a quote from somebody who looks like Donna McDonald, who has since retired. but we're just a small group of people and we can make huge impacts when we do projects together and we support one another. So I think it's pretty cool, and it's all about the patients, and from improving patient care, we're improving so many other things too that we probably don't even realize. So great job. Okay. I'm going to do questions. In the meantime, I'm going to leave that slide up if you guys are interested in it. All right, Sean, can you remind us which month date WebEx you hosted that explained how to understand risk adjusted, especially the star rating section in the IQVIA dashboard? Do you remember when that was, Melinda? We've done it a couple times. It was after one of the last harvests, probably after harvest 1. Sean, if you want
Probably
to
just-
email me.
Or just email me. I'll have to research it and find out when it was done. Send it to me in the mailbox, Sean.
Thanks. Thanks, Melinda. I think it was done after harvest 1 release. When will we receive CEU certificates for attending the last AQO? Already answered the questionnaire. So they're being processed once a month. So within a month of you completing it, you should be receiving it, Mary. Oops. Rita, regarding updating our ACSD contact list by October 27th, our surgeon rep has left and moved to another facility. We don't currently have a full-time surgeon to replace him, but may soon, but likely not before October 27th. Rita, if you want to contact the STSDB at sts.org, they will be able to best direct you with your question. And I think Leanne can answer your question. She'll put that in the chat box, the email address in the chat box for you.
Yes.
When will the publicly reported data be updated? I think in the notification that went out from our database operations team that it will be updated using Harvest 3 results, and it should be updated within by the end of the year. When did our vent time project? We did our vent times project many years ago and have median times of 3 to 4.5 hours for the last 5 years. Kim, I'd love for you to present on that if you're willing. I know you would be an awesome presenter, so please let me know if you're willing to do that, or anybody on your team would be willing to do that along with you. And I'm happy to get you on the schedule. We would love to hear from you. And you should be very proud of those mean vent times. I wonder which one of these sites you are. Just kidding. Okay. Further info pre-op beta blockers need formal info for our upcoming M&M. And we are finalizing the data collection form after everybody's great feedback. So we had a beta blocker webinar on October 4th. It should be posted to the website today. I am told by our marketing team it accidentally found its way into a junk folder when I sent it over to marketing, not because they did it on purpose, but just because sometimes emails act funny, and it never got posted. So I should have checked for that to make sure it was posted, and I did not do that. So it
It's
was
out there,
my
Carol.
thanks. So it's posted now for October 4th. And if you join that webinar, or if you watch that webinar now, you're going to have questions about what's going on with the beta blocker project. Melinda and I have met with our surgeon leaders after reviewing all of the comments we received in emails and from the webinar. We made changes to the data collection form. We're finalizing it now. We're at the very end of it, and I will be planning a call to discuss the changes with the surgeons. In addition, Melinda is working on training manual information for the training manual supplement to cover those fields. And we're going to work with our surgeons on formal communication to the surgeon and participants for our databases. So I don't have
Carol,
any more information than that right now.
I think maybe an updated ETA on when we might launch that. I think.
Yeah, I don't have a date. I think we were hoping by the end of the year. Our facility actually has always done pretty good in vent timing. As a data specialist, they just want me to gather the data. So everybody has a different role at their hospital. Gathering the data is as important as using the data so you understand what you're gathering. And if you see something off, you can let folks know that something doesn't seem right. You're kind of like the first person. And it depends. Everybody has a different role at your facility when it comes to the database. But hopefully, if you have a quality improvement team that would like to hear your feedback, they'll take that feedback and be able to do something with it. We have been ahead of the curve on vent management. We have awesome nurses and protocols. And Sue, I would love to have that information for you to share that information on an upcoming webinar. If you're interested, please email me at ccrone@sts.org. QI projects tend to occur amongst the surgeons and residents and typically do not involve me. For example, we have a blood usage QI project going on now, but I am not involved. Maybe you can be involved, or ask if you can be involved. What do you think you can lend to that team? Are you the one who's looking at your STS reports and doing any type of interpretation on them? Are you sharing that with your surgeons? How are they tracking this? Are they using the STS database? Do they understand what the benchmarks and like groups are? See how you can get involved in these, because I think we have data managers are very intelligent people. We wouldn't be you wouldn't be doing this job if you didn't if you didn't have the ability to see the data in a way that can be helpful. So what you see in the data, how can you share that? Are you seeing, when you're abstracting cases, are you seeing patients that you're questioning, well, why the heck did they get that many units of blood? And if you are, then are you able to pass it along to somebody to say, hey, I just noticed this, what's going on? And same thing with vent times. Why was this patient? That it's where the projects start, or how they come to life at facilities, and how you can be a part of it. I think sometimes you might have to be a little out of the box thinking on it, but nothing comes if we don't have people that want to step up and take a chance on it. So I think you can become part, Marina, of that. Any chance of an extension deadline for H4? No, we're not planning to extend the deadline, but it is set for November 10th. Could there be a metric on the report for discharged on antiplatelet? In other words, a combined metric for aspirin, ADP, and other antiplatelet. Let's see what we have now.
You have the NQF metric for antiplatelet already.
Yeah, let's see what we have.
Should be under NQF.
So we have, let's look at, that's a process measure. The medications are process measures. So let's look at the process measure. Give this a second to populate, though. We have to let it run.
There it
Yeah,
is.
when we look at antiplatelets, it's this is combined here on the NQF page. This is isolated cabbage. And this is your participant score, your percentile. So this participant had a 99.37. This measure is pretty pretty hard to compete in to achieve 100%. It's also that there are a lot of folks who fall within this, between 99.85 and 100%. That's 50% of the whole population that's participating in this measure. So it's hard to get a percentile when this site score is 99.37. It's going to fall below the 50th percentile. And for purposes, it's at the 25th. When we look at the 10th and 50th percentile, it's going to fall somewhere right in here. So that's that. And then I think We don't have it. That's for isolated cabbage. Oops. And for all cardiac surgeries, we just look at the timing of timing and selection, duration of antibiotics. We don't have a metric for the, we don't have there's not a process measure for the other cardiovascular operative procedures outside of the isolated cabbage right now.
Unless Tracy's got a different question that, you
Yep,
know what I
Tracy.
mean? I'm trying to read into this question because I think there might be more to it, Tracy, but if you want to raise your hand, elaborate, or send a question into the mailbox, be happy to help you.
Yeah, thank you. So Hannah, we looked at average or mean, the mean.
Hannah's also had her hand up too, Carol.
Oh,
I don't know if she wants to talk
oh,
or not.
her hand's down.
Now Carrie raised her hand.
All right, let me get through these questions real quick here. Is there a way to know what site number we are? Nope, can't tell you what site number you are. Sorry. We like to be considered for sharing our prolonged QI efforts. Thank you, Melissa. Yep, definitely we'll reach out to you and happy to do that. If you could email me at ccrone@sts.org so I don't lose that information, that'd be very helpful. These are total vent hours. Would it be worthwhile to see if there's a decrease in prolonged vent for all sites over time? Yeah, that's what we looked at. So that was one of the last slides we looked at was the prolonged vent. And we try to keep to remove outliers when we look at averages like this. We try to remove outliers. So could you produce the percent within 6 hours and percent within greater than 24 hours, even though they are on the dashboard for national, but by site, this would be, let me talk to our analytics team to see if they can share that data with me. Yeah, prolonged vents there. Is it median the, I don't know. I don't know. I prefer average just because it looks at everything. It's not the middlemost value. So if you have, it's probably pretty close. I think when we look between median and mean, we can look at the STS here and see where we're at, what those look like. And if they're that different, we can certainly include both of them and follow up presentations about the reports. Let this load up real quick. Do we have a numerical target for this project overall? I have to go back and see what we came to. Yeah, Mary says, thanks for presenting, very interesting. She would love to know the sites that are doing less than 6 hours. So somebody did put in a comment that their mean average time was 3.5 to 4.5 hours or 4 to 4.5 hours for about 5 years. This is the whole purpose of these types of webinars, is so we can connect folks with each other, and hopefully those people that are having a very successful decrease in vent times do want to come and share that information with everybody so they can also improve at their local sites. So what was I looking at? Oh, the mean. So let's look at isolated cabbage. And we'll look at post-op information. Yeah, and Colette, you asked a question, have there been studies indicating that extubated in OR improves outcomes or length of stay versus patients extubated within 12 or 6 hours in the CVICU? On that first webinar back in April, presented information on all of this. Dr. Whitman presented additional information on on all of this. There are studies that show, the patient has to be right for extubating in the OR. The patient also has to be right for extubating within 6 hours or in 12 hours, and different protocols to help with that, how to identify those patients, and then how those patients that were appropriate but did not get extubated within that 12-hour mark, there was information shared on the additional increased risk that those patients face when they're intubated greater than 12 hours. So there's quite a few articles out there already. If you're interested, you could go to your medical library, have them pull up the articles, or do a Google Scholar search. That's what I did, and found quite a few articles on that. All right, so so this is mean vent time is way different. This is one site. They had, I don't know what their N was, but we're looking at the STS average. The mean 14.42, the median is 4.9, right? So I focus on the mean because that's the average. The median is where most patients are extubated, but we got to consider that there's patients who are going to drive up the mean rate. So I like the mean. If you can give me a good reason to use the median, we can report on both. But I don't think a median of this is going to be very helpful, right? If I have a mean vent time of 14.42, that means that my average patient is going to get off right around the 14-hour mark. I don't know. I think there's benefits in both, but if you can share why you prefer median over mean, something we can certainly consider to do. Who do we reach out to for information needed by October 27th? I think, Leanne, did you put the stsdb@sts.org email address in the chat box? That's for the updating your contacts.
I think that question actually has to do with the beta blocker protocol.
No, that was October 27th is the deadline to update your participant contact list.
Oh, because Rita asked that question. That's the only reason I'm saying this is Diana. So
going back to the beta blocker initiative, will you be sending out the draft out as requested on the webinar? Yes, I will be sending out the draft once we have it near final. I don't want to have version control issues and folks, and it cause any confusion with having multiple versions out there. So once we get it near final, it's just about ready to go. I'll circulate it out to those. I have saved everybody's requests, both from the webinar and who emailed me. So I'll be doing that, but not yet. I have to work on the Harvest 24 deadlines. So those deadlines haven't been picked yet, but they will be similar to 2023. Do I contact IQVIA if I'm getting an error attempting to download the Harvest 3 report? Please email, Leanne, could you please put the email for the STS database help desk in the chat box? I think Leanne's still there.
Yes, ma'am, I'm here. I'll put it in the chat. I'm sitting here talking to myself on.
Thank you, Leanne Jones. Public data release anytime soon. Last I heard it will include Harvest 3 2023. Yep, that's correct, Dustin. That's absolutely correct. Any sites using methadone intraoperatively to the audience? Let's open up the chat box and anybody can answer Kim's question on that so we don't go into the Q&A. Kim's asking if anybody is using methadone intraoperatively. Go ahead and,
looks like Nancy Honeycutt is. She already responded in the Q&A.
Oh, did she?
Mm-hmm.
Well, Nancy and Kim know each other. They can talk all about it. Yeah, I understand about the 2 very sick patients, but I do try to look at the outliers, and we have, but I hear you, Hannah. Let me talk to our analytics team and see what they think about that. Well, about what's the best to report out for this project. For a low volume site, one outlier can really skew the average. Yeah, we try to look at those and don't include them when we have all of the sites vent times, and we try to cut off the outliers when we do the averages. Nancy Honeycutt, there are studies that show reintubations go up with OR extubations. Yeah, patients have to be appropriate for OR extubation. Patients need to be appropriate. Some places have done really well with OR extubation protocols. Where I used to work, almost every patient came out of the OR extubated and awake. And then another place I worked at, patients didn't get extubated until 23 hours and 45 minutes. So it's all different. And I think it's, okay, thank you. I just started my role in July this year. I will go back and look at the webinar. I am mainly interested in intra-op extubation versus early CVICU extubation. So Dr. Whitman did a great presentation on that, Colette. If for some reason the presentation should be on our YouTube channel, and it was the middle of April 19th, I believe, that he presented that. Yeah, I agree, Jackie. When mean and median are similar, the data is more meaningful. A very different mean than median means we just have some very significant outliers that is not indicative of normal care. That's a good point, Jackie. Thank you. The median smooths out the outliers. You could have two, yeah. And Valerie uses methadone. Valerie Cassidy uses methadone. And Susan Spaniel says she just saw it for the first time yesterday with a new anesthesiologist. Sue Vincent says they started it 9 months ago with a new surgeon. Every patient gets it. All right. And I can't remember, do you remember the numeric, if we started a numerical target? I think we just wanted to see where it went with the first, and then we were going to see how good we could get.
Yeah, I don't think we had a target in mind.
Yeah. Yeah, Karen, I saved your question. I'm going to ask this is about, could you provide the percent within 6 hours and percent greater than 24 hours? So I certainly can ask them to do that per the site level, similar to what we're doing for the mean. And I'm happy to do the median as well. We can look at the extubated in OR. The national percentage is 4.35%, but we can look at it based on the total participants, and then we could break it down by low, medium, and high volume sites. And we can also look at, you said the prolonged ventilation, and that was what we had looked at. I can have them pull that information, not just risk adjusted, but we can look at it across the sites the same way we do for the other vent hours. And I think there's some really great conversation going on in the chat about methadone use, so thanks for sharing that. And then I see, Carrie, you have your hand up. If you want to go ahead, if you can unmute, go ahead and unmute and feel free to. Okay. All right, great conversation, everybody. Great conversation on the methadone use happening in the chat box. And maybe if anybody wants to present more detailed information on methadone on an upcoming webinar, please reach out to me. I'm happy. It sounds like that would be something that your anesthesiologist or surgeons are maybe implementing for extubation, improved extubation times, or improved the changing the use of the anesthetics that the patients are getting into operating room to maybe wake those patients up quicker. But happy to, I don't know a whole lot about it. I'm just reading the messages that are coming through. Happy to have you present on it. Christina just sent in, how's the OR times for those facilities with high rate OR extubation and extubation within 4 hours? Our facilities mean OR time for isolated cabbage, 224 minutes. And our mean initial vent time is 5.5 hours. Both of these variables are below STS. That's great, Christine. Is there a way to see what the vent times by on pump, off pump are? Does this make a difference? That's a good question. And I think we have that in the benchmarked reports already for at least for the, hold on. We have it in the benchmarked reports already on the IQVIA platform. See if I can quickly get there. And we can see just from looking at the, oh, I guess we're over time. I apologize, everybody. Just by looking at the STS average, we can see if there's differences. So we have, to give this a second to load. We have a average vent time of 14.42 hours. That was for all PROC ID 1 cases. An STS average, it's a national average of 14.42. We can look at on pump and off pump. So let's look at on pump first. And give that a second to load. So we said 14.42 for all cabbage cases on and off pump. And then this is on pump. Vent hours, mean vent hours is 15.59, so a little bit higher than national average. So my guess is that when we look at off pump, it's going to be a little bit lower. So 15.59. Oh, hey, that's the light group. Sorry about that. I thought I pulled up 14.478. So pretty close. 14.42 for all cases, 0.478 for on pump cases. And then when we go back to off pump cases, I don't know why my screen gives me such a hard time. I just wanted the little house button. Go to off pump cases. Would be nice if I hit the right thing. Post-operative information tab. Like I don't, hold on. STS light group mean vent hours for. Am I in the right row?
Looks like it.
Mean hours is 11.4. And I don't know, I have a hard time with mean or median. I think mean is a really true reflector of how the site is performing. That's all your patients. You're not I could see how it could be beneficial for depending on your volume of sites both
Yeah.
ways.
I always like the mean, me personally. To me,
I
it's
don't,
more meaningful for me, but I'm not saying that for everybody.
yeah, I think you could have difference of opinion on it, but I'd like the mean because I don't think you're leaving off the outliers. Now, if we know that there's, yeah, the mean is different, a difference of 3. So could it be that they had a very sick patient, sicker patients are having on pump versus healthier patients are off pump? I don't know, maybe,
Well, sometimes the sicker patients are off pump. I mean,
right? And that's what I always thought too. But when you look at this, this is off pump, the mean value's lower.
but they're not on pump, which is a significant insult just in of itself being put on that pump. So, to take those
Yeah.
factors away too. So, I would expect, if I hadn't even looked at the data, I would have expected the off pump patients to be lower, just based on not being on the cardiopulmonary bypass machine. So,
Yeah, all that bad stuff that happens inside your body from the bypass machine, right?
yeah.
And it screws up it, yeah, okay. So I mean, I guess that's, I would say, I still like the mean on those, but we can report out both. I'm gonna have to get some extra help here to help me do all these slides. Melinda.
Oh, I was thinking of Hannah. I bet she's really good at slides. I've seen her graphs before. Hannah, I've seen your graphs before. They're excellent. She's probably not laughing. I've known Hannah for a long time. So, thumbs up. Maybe that's Hannah.
All right. Well, thanks, Melinda, for joining. Great job. I think we should, this will be posted in the next couple, hopefully by the next week. I'll make sure our marketing team gets it this time. And thanks for joining, everybody. You should be very, very proud of everything we're doing together. Do I have? Yeah, so Carrie says our hospital is greater than 95% off pump, and they have a greater than 85% extubation in less than 6 hours.
Yeah, that's what I expected. I would expect that.
Yeah. Welcome, Cyrus. All right. Well, thanks everybody for joining. Thanks, Melinda. Have a great day, everybody. And we have our next webinar coming up sometime. I don't know where the slides went.
It's November the 1st, right?
Did I stop sharing my screen a long time ago?
No,
just now.
Just
Oh,
now.
okay.
Yeah, you're fine.
Oh, Lord.
November the 1st.
I'm like, I have so many things on it. I'm like, oh, no, I hope I wasn't talking this whole time without sharing screens. Dear Lord.
No, you're fine.
Oh, my goodness. Okay. All right. Thanks, everybody. Have a great rest of the day. And thank you, Melinda.
All right,
And
bye,
thank you,
everyone.
Leah and Jones.
Carol.
Bye.
Bye.